the quiz, isn't it?
Right. You can introduce the course and start the quiz. Then Patrick can introduce Brad Robin.
Okay. Okay.
Thank you. So Brad, if you just allow Rasha, she's going to present the quiz before your presentation. So if you allow her to share her screen, then you can go ahead, Dr. Ala, and introduce the meeting and get started.
All right, I'll stop sharing.
Okay, should I start now?
Please.
Hello and good evening for everyone in Egypt and in Arabic country, and good afternoon for our colleagues from the United States, from the other side of the world. I'm really honored to be among the organizers and the moderators of this fascinating event, and really it's very wonderful to see all of you here. Today, this is the second day of the second course entitled Glomerulonephritis 2. It's a part of a sistership program sponsored by the ISN between Mansoura Nephrology and Dialysis Unit, Egypt, and the University of Kentucky Nephrology and Wound Metabolism Unit from United States. This is our agenda today. We'll start the activity by a quiz presented by Rasha Samir, lecturer of nephrology, Mansoura Nephrology and Mansoura Nephrology Unit. Please, for the attendee, write your answer in a paper, and at the end of our event, Rasha will give you the model answer and compare between your answer and Rasha's answer. Second, we'll move to a very interesting presentation presented by Professor Brad Robin from the nephrology, Professor of Nephrology, Ohio State University, who will try to answer a very difficult question about lupus management. And after that, we'll have an interesting case presentation presented by Shayma Abdeljalil, a lecturer of nephrology, Mansoura School of Medicine, about refractory lupus case and its management. And the fourth presentation will be by Professor Siddiq Ahmed, Professor of Nephrology from University of Kentucky. If you attended yesterday, we have a very interesting presentation from our Professor Muhammad Sabh about the ANCA-associated vasculitis. So hopefully Professor Siddiq will solve the debate we have discussed yesterday about the use of plasma exchange in the management and as a therapeutic modality for cases with ANCA-associated vasculitis. And after that, we'll have another case presentation presented by Sam Bevan from the nephrology unit in Kentucky, who will present a case of ANCA-associated vasculitis and its management. And at the end of the day, Rasha Samir will give answers for the quiz she has presented, and at the end of the day, we'll summarize and conclude. So if you allow me to introduce the moderators for today's meeting, I have the honor to introduce Professor Patrick Neckman, Professor of Nephrology, University of Minnesota from the United States. My colleagues, Professor Dina Shaheen, Professor of Immunology and Dermatology, Mansoura School of Medicine, and Professor Ahmed Abdel Wahab, Professor of Nephrology, Mansoura School of Medicine. Hopefully, you will enjoy this event. Rasha, please start your quiz.
Okay, Dr. Ala, thank you. I have the honor to participate in this great course presenting Day 2 quiz. My questions will be relevant to the lecture of Professor Rubin regarding the newly introduced drugs in lupus nephritis, and the lecture of Professor Sadiq regarding the plasma exchange. So is my screen on?
Yeah.
Yes.
Yeah, great, Rasha, go on.
So the first question is, which one of the following combinations represent the first-line therapy for patients with active class 3 and 4 lupus nephritis in view of the current literature? Steroid plus cyclophosphamide MMF, steroid plus belimumab, steroid plus CNI, cyclosporin, vocalosporin, MMF plus CNI, MMF plus belimumab. Question 2. Which one in the following is the most reported adverse effect with the use of vocalosporin via the clinical trials, in particular the Aurora 1 trial? It's hyperglycemia, infection or infectious complications, pneumonia, tremors, alopecia, and hyperlipidemia. Question 3. Which one of the following represents the mechanism of action of belimumab? Blocks the binding of soluble-Bliss, a B-cell survival factor, on receptors of B-cell, or targets the CD20 antigen on B lymphocyte, inhibits CNI or calcineurin signaling to activate T lymphocyte, inhibits furin senses needed for the synthesis of immune cell, or induces T regulatory cell and T cell growth factor. Question 4. Which one of the following is correct regarding the use of belimumab in management of active lupus nephritis? A. It should be used as monotherapy in patients with active class 3 and 4 lupus nephritis. A combination of methylprednisone plus belimumab should be used in patients with class 3 lupus nephritis. Belimumab is considered in patients with active lupus nephritis on a background immune suppression of steroid plus MMF cyclophosphamide, or there is no evidence supporting the use of belimumab in class 5 lupus nephritis, or long-term use of belimumab confers better safety profile compared to the traditional immunosuppressive therapies. Question 5. Which one of the following regarding the use of vocalosporin in management of lupus nephritis is incorrect? It's the new generation CNI with similar potency to inhibit the activity of T cell, as cyclosporin or tacrolimus. It has better metabolic profile compared to other CNIs. Low-dose vocalosporin has shown high complete renal response rates in clinical trials. Vocalosporin is recommended as add-on therapy to MF and low-dose steroid in patients with active lupus nephritis. Monitoring of the trough levels of vocalosporin is mandatory to prevent overdosing. Number 6. 6-year-old patients admitted with fatigue and lethargy. Initial laboratory tests reveal hemoglobin of 8 grams per deciliter, elevated reticulocyte count, LDH of 850 international unit per liter, serum creatinine of 2.3 milligrams per deciliter. His urine sediment is planned, and peripheral smear shows mini schistocyte. A serum sample is drawn for further testing, and pending hematology consult, what will be the next step? A. Start plasma exchange, await Adams 13 levels, start pulse steroid, start heparin, continue observation. Question 7. A patient with hepatitis C had the onset of uncontrolled hypertension, leukocytoclastic vasculitis, of the lower extremity, AKI. The biopsy shows crescentic type 1 membrane proliferative GN, secondary to cryoglobulinemia, with no evidence of chronicity. What treatment option is recommended for this situation? Initiation of hepatitis C antiviral therapy, plasmapheresis, corticosteroid, rituximab, or all of the above. My last question. A 55-year-old has been previously fit and well, present to the acute medical care with an episode of hematuria and AKI. He gives no history of previous respiratory symptoms. An ultrasound of the renal tract is normal, but a renal biopsy taken shows acute glomerulonephritis with a linear immune fluorescence staining. His anti-GBM antibody is positive. Which therapeutic modality accordingly will be the most likely to be beneficial in the next few days? Intravenous immunoglobulin, plasma exchange, acypran, prednisone 20 mg per day, mycophenolate mofetil plus prednisone 20 mg per day. Thank you.
Thank you very much, Rasha, for this well-selected questions, and we'll move to the first speaker. Professor Patrick, please.
Okay. Rasha, can you, if you stop sharing your screen, I can share mine.
Okay.
All right. I think we're good to go. Patrick, are you going to introduce me?
Well, first, I want to thank the organizers for inviting me to be part of this exciting course. It's really a pleasure to introduce Dr. Rovin. As Dr. Sabri said earlier, Dr. Rovin is Director of Nephrology at The Ohio State University in Ohio. Dr. Rovin is really the epitome of the triple threat, phenomenal educator, phenomenal basic science, translational science, and clinical science researcher, and obviously an expert on glomerular diseases and phenomenal clinician. Dr. Rovin has and does and continues to participate in the design, implementation, reporting, analysis of many landmark studies, notably lupus nephritis. Brad, it's a pleasure having you here.
Thanks so much for inviting me, and I'm happy to be here. And as I told Dr. Sabre, going to Egypt is on my bucket list of places in the world to visit. So someday I'll have to come by. So I thought today we could talk about the newly approved drugs in lupus nephritis, because they're causing a lot of confusion in terms of what people should do and when. And I do want to have my disclosures here. I'll just point out that I work with a lot of companies, but I do work with the companies whose drugs I will be discussing today, but I will give you hopefully a balanced presentation of the data. So I want to just bring everyone up to date as to where we are right now. You can see that, let me move this out of the way. You know that in the United States, the FDA has approved Vocalosporin and Belimumab for the treatment of active lupus nephritis based on two randomized controlled trials, phase 3. This is the Bliss trial for Belimumab. And I'm not going to go through it in detail, but I just want to point out a couple of very interesting aspects of the trial. At the time of randomization, the principal investigator at each site could choose the background therapy to which Belimumab was added. And that could be either mycophenolate followed by mycophenolate for maintenance, or low-dose cyclophosphamide, so the Euro-Lupus cyclophosphamide protocol followed by azathioprine. Belimumab or placebo was added, and then by week 24, steroids had to be tapered to below 10 milligrams a day. Another sort of innovation as we tried to move towards using less glucocorticoid in our patients. And then the other important aspect of this trial is that it was analyzed at 2 years, not 1 year. And that's really important for some of the B-cell drugs, as we'll talk about. So the primary endpoint of the Bliss trial was called the primary efficacy renal response, or PERR. It's a little bit different than complete renal response, although that was also assessed. Complete renal response has a more rigorous proteinuria value that you have to get below, 0.5 compared to 0.7. And the GFR had to be much more strictly controlled. So GFR had to be above 90 and could not fall more than 10% below the pre-flare value. Whereas in the PERR, the GFR had to be above 60 and could have fallen by about 20%. This is the design of the Vocalosporin trial, the phase 3 trial. We used Vocalosporin, which of course is a calcineurin inhibitor, plus a moderate dose of mycophenolate plus glucocorticoids. and compared that to placebo plus the same dose of mycophenolate and glucocorticoids. This trial's primary endpoint was complete renal response in the traditional sense, and this was done at week 52. However, this trial also had a very unique design. It was using a very low starting dose of prednisone, 20 to 25 milligrams a day, which for most people is about 0.3 milligram per kilo per day. And then you can see this is the forced tapering schedule. And you can see that very quickly the dose of glucocorticoid was brought down so that after 12 weeks, patients were on 2.5 milligrams a day. Now, importantly, this rapid taper was accomplished and tolerated by 80% of the patients in the trial. So this went very well. These are the top line outcomes. I think you're all probably aware of this by now. There's been a lot of press on this and a lot of papers written. And these are maybe not the most important results, as we'll go into. These are the results for the Bliss LN trial. This is the primary efficacy renal response, as well as the complete renal response. And you can see here that in the patients treated with belimumab, they achieved more PERR responses and CRR responses than the patients in the placebo group. And the delta here for both endpoints was about 10% advantage in favor of belimumab. What I did here is I compiled the data from the phase 2 Vocalosporin trial with the phase 3 Vocalosporin trial. So we're looking at data from over 500 patients. And as you can see, by 6 months, the patients in the Vocalosporin arm had significantly more complete renal responses than the patients in the placebo arm. This continued on for the entire year. And actually, the difference between placebo and active therapy was about 20%. So that increased over the course of the year. Importantly, as you well know, we're taking additional immunosuppressive agents and adding them to already pretty robust immunosuppression regimens. However, no specific safety signals were seen in the phase 3 trials. If you look at overall in the Bliss LN trial, serious adverse events, they're about the same between the active arm and the placebo arm. The same is true with vocalosporin. If you look at serious infections, again, the same between the two arms, and again, the same thing for vocalosporin. Roughly the same percentage of patients in each arm of each trial discontinued because of adverse events, and deaths were very few, thank goodness, in all the trials, and were similar between the arms. So I want to throw this up here because I'm going to come back to this idea on the very last slide because it's a really important point that I think we all need to think about as we're treating our patients with lupus. These are data out of Rush University in Chicago. They're a little bit older now, but I think they're very important. So this is kidney survival in patients with lupus nephritis who have achieved a complete renal response. And you can see that over a long duration of follow-up, these patients maintain kidney function pretty well. As one would expect, if you had no response, then you're at the bottom curve here, and your prognosis for kidney survival is markedly diminished. However, this is really the interesting line. This is the patients who've had a partial response. We all see a lot of partial responses in our practice, and I think it's important to realize that this is probably not enough. This is not good enough for our patients because you can see that even though a partial response is better than no response, a lot of patients go on to lose kidney function in the partial response group. So right now, at least in the United States, we could just treat everyone with background immunosuppression plus belimumab or vocalosporin. But I want you to consider these points. First of all, what drugs should we add on? We really have no biomarkers to identify who's going to benefit most from belimumab or vocalosporin. These medications are very costly. They may be a barrier for many patients, not only in the United States, but also around the world. Some countries their healthcare systems may not be able to afford this, and the patients will not be able to afford them. The new medications are not really reducing the immunosuppression burden for our patients. And while I just showed you that adding them to background therapy is safe in the short term, long-term safety data, especially for Vocalosporin, are really lacking. Now, our rheumatology colleagues have been using belimumab for well over a decade, and we do know that long-term treatment with belimumab is relatively safe. Adding on to the background therapy increases the pill burden and the polypharmacy that we expose our patients to. And this is really important because, as you know, most of these patients are young and they have significant issues with adhering to medications. And finally, a significant proportion of patients will respond to background therapy alone. So I want to try and convince you that if we look at the trial data in depth beyond the primary endpoint, I think it'll help us inform the use of these new medications. So let's start off with the Bliss trial. One of the things we did was do subgroup analysis of the entire population. And we found the following. These are all forest plots. And what this shows is that for both the PERR endpoint and the complete renal response endpoint, belimumab is favored, but most of this is being driven. In fact, all of this is being driven by patients who were treated with belimumab plus mycophenolate as the background. Those with cyclophosphamide did not see a significant improvement with the addition of belimumab. When you look at the histology of the patients who were enrolled in the trial, again, belimumab is favored, but this is being driven by patients with proliferative lupus nephritis, primarily proliferative lupus nephritis. The point estimate is still pretty good, although not significant, for patients with proliferative plus class 5 lupus nephritis. And belimumab has no effect, no apparent effect on patients with pure class 5 lupus nephritis. Now, a caveat is that, of course, most of us would say that the tempo of the disease and the response for class 5 lupus nephritis is different than those patients with proliferative lupus nephritis. In addition, the percentage of patients that had pure class 5 overall was smaller in this study, and also you'll see in the Vocalosporin study. This is a really important sub-analysis. We looked at proteinuria levels, and we defined low proteinuria as less than 3 grams a day, and high proteinuria as patients coming in with 3 or more grams a day. And what you can see here is that belimumab works in patients who have low proteinuria, but it has no effect on the patients who are coming in with high proteinuria. Now, some other things were able to come out of this trial, primarily, in my opinion, because this was a 2-year trial. We were able to look at the effect of belimumab on lupus nephritis flare in the population. And what you see here is that in almost every category, overall, cyclophosphamide background, mycophenolate, the different lupus classes, belimumab does better. In other words, there are fewer lupus nephritis flares in the patients on belimumab. And then the other important thing is, what's the effect of belimumab on kidney function? Again, because this was a 2-year trial, we were able to look at the slope of change of GFR over time. And as you well know, a negative slope means a decline in GFR. And you can see here that the decline in GFR in the placebo group is numerically much less than in the belimumab group. This didn't quite reach statistical significance. Of course, this was not powered to look at this endpoint. We also looked at a 30 or 40% sustained decline in eGFR. Again, something that our FDA is looking at as a potential endpoint for clinical trials of kidney disease. And you can see that far fewer patients in the belimumab group, significantly fewer patients, reached these poor endpoints. Belimumab was used, we divided it up into patients who had newly diagnosed disease or relapsed disease. And as you can see here, both groups of patients responded to belimumab, but belimumab did really well in patients with relapsed disease. Think about this. These are patients who have already been exposed to immunosuppressive therapy. And I'm going to come back to this when I show you an algorithm towards the end. Okay, let's switch gears to the Vocalosporin trial. And we did a subgroup analysis in the Vocalosporin trial. As you know, outside of white patients, European ancestry patients, other patients don't do very well, or their lupus nephritis tends to be more aggressive. So we did a subgroup analysis looking at different races, and you can see that Asian patients, Black patients, and other patients enrolled in the Vocalosporin trial all did very well. If you look at ethnicity divided into Hispanic or non-Hispanic ethnicity, both groups did well. Again, I want to point out that the point estimate for pure class 5 lupus nephritis is favorable with vocalosporin, but it does cross the line of unity, meaning it did not reach statistical significance. I think in this particular case, this is a numbers game. The total percentage of patients that were pure class 5 in the overall trial was rather low. And one more thing that I think is important. If you look at the patients who are using mycophenylated screening versus the patients who are not using mycophenylated screening, you can see here that vocalosporin was quite good in patients who already were receiving mycophenolate, in other words, already exposed to immunosuppression. And I'm going to use that theme later, as I said. Okay, this is how rapidly protein resolves in patients in the vocalosporin trial. And you can see that in a matter of days, the two lines separate. The blue line is the vocalosporin group. And you see that this separation increases. This is the probability of the urine protein creatinine ratio going below 0.5. And you see that this remains above the placebo group throughout and widens as time goes on. I think you'll all agree that a rapid anti-inflammatory response is kidney protective using traditional immunosuppression. And I'll show you just one set of data. This group looked at patients who remitted early with traditional immunosuppression and patients who remitted late. This was about 50-50 patients, and this was a very long-term follow-up. You see that the GFR in the early remitters was better preserved than the GFR in the late remitters, and that was statistically significant. In addition, the percentage of patients developing chronic kidney disease was about half in the early remitters versus the late remitters. That did not reach statistical significance. Now, what I'm showing you here, the very rapid response with vocalosporin is almost certainly not because of its effect on T cells, but is likely because of its effect and the group effect of calcineurin inhibitors on podocytes. I'm going to suggest that the podocyte effects are also kidney protective. So as you all know, calcineurin mediates the dephosphorylation of synaptopodin. It makes it susceptible to digestion by cathepsin. Synaptopodin is critical for stabilizing the actin cytoskeleton, and therefore calcineurin inhibitors are able to protect synaptopodin and the actin cytoskeleton of the podocyte. How does that translate over? Well, I like this experiment very much. This is looking at tacrolimus in the lupus nephritis mouse, the MRL-LPR mouse. And what we're looking here is synaptopodin message. It's easy to see here as it's quantified. So the mice are taken from birth, and then 8 weeks, they're aged 8 weeks, and then the experiment starts. They're either left alone, normal mice are left alone, MRL mice are left alone, or tacrolimus is started, and then 8 weeks go by. And you can see that in the normal mice, synaptopodin is normal. In the MRL-LPR mouse, the message for synaptopodin is markedly diminished. And if those mice were on tacrolimus, that message is maintained. It's not going away. This also is seen in terms of podocyte number, a normal number of podocytes in the control mouse. You're losing podocytes in the MRL mouse. You've actually kept your podocytes in the tacrolimus treated mouse. This is a really dramatic picture. This is foot process fusion occurring in the MRL LPR mouse. And you can see that at the same time point in the mice treated with tacrolimus, you're maintaining the foot processes in this mouse model. And of course, you also maintain the slip pores as well. Why are podocytes important? Well, here, these are human tissues, but here you see this is normal control. Glomerular capillaries are in red. The podocytes are stained with WT1, against WT1, and they're in green. Normal number of podocytes covering the glomerular capillary basement membrane. You start to get some microalbuminuria. You see the podocyte density is down a little bit. As you increase the amount of proteinuria, you're losing more and more podocytes. If you start to lose the density of podocytes, here's a 10% loss, 20% loss, 55% loss, you start to develop glomerulosclerosis until eventually the glomerulus is gone. And what you see here is just a plot of podocyte number, podocyte density on the glomeruli. And as you lose podocytes, GFR declines. You look at the work out of Michigan with Roger Wiggins' lab. He suggests that if we lose 40% of our podocytes, and this is probably a cell that is not easily replaced, that no matter what happens to the original disease, you're actually going to lose that nephron. It's going to die. And this is how you move on as the disease is controlled towards end-stage kidney disease. The question of calcineurin nephrotoxicity always comes up. I don't have the answer. I'm going to give you some suggestive data that maybe nephrotoxicity is a little bit less in vocalosporin, but this is not proof. This has to be proven side by side. Rabbits are very sensitive to calcineurin nephrotoxicity. These rabbits were either not treated, so they were control rabbits. They were given cyclosporin A, and you can see that over 1 month, their serum creatinine increased. And then they were given low dose and high dose vocalosporin, and you can see there was no real increase in serum creatinine. This looks like creatinine decreased. I don't think that there's a true improvement in serum creatinine or GFR in these rabbits. For human studies, I've cobbled together information from different studies, but these are not, these are not all within one study. So you have to take this with a big grain of salt. This is transplant patients, and we're looking at cyclosporin treated. About a quarter to a third of the patients develop kidney dysfunction. And if they were treated with vocalosporin with levels that were low, medium, or high, nobody developed kidney dysfunction. So that's sort of interesting. This is an example of a study using calcineurin inhibitors for psoriasis, either cyclosporin or vocalosporin. And you can see that in the cyclosporin group, about 20% of the patients developed an increase in serum creatinine. In the vocalosporin treated patients, about 1 to 6% developed a reduced GFR. And this was in the dosing range that we used in the lupus nephritis trial. So does this mean that there's no nephrotoxicity? Absolutely not. It needs to be investigated, but it's sort of suggestive. I'll also do this. I'll show you the long-term vocalosporin data. After the Aurora trial was stopped at finished at 1 year, the patients were asked if they wanted to stay on for 2 more years. And what you see here is the patients who were receiving vocalosporin had, as expected, a small decline in GFR when the drug was started. That was maintained and did not worsen throughout the next 2.5 years. And I think at the ERA EDTA, they presented the 36-month data. Now, a lot can be going on in the background. To answer this question, it would be nice to have kidney biopsy to see if any tubular interstitial damage had been occurring. But these all sort of suggest that vocalosporin may be reasonable to use for at least a 1-year time frame as it's been approved for. Okay, I think it's important to go over the costs of these, and this is US dollars. This was recently published in CJSON. They assess the incremental cost effectiveness in terms of quality adjusted life years. I'm not a healthcare economist. If you read this paper, it's really complex modeling, and I'm not entirely sure I understand the modeling, but I will go over some of the assumptions that are made because I'm not happy with some of the assumptions. First, I'm going to present the results. This is the cost effectiveness per quality adjusted life year. For belimumab, it's estimated at about $95,000 US dollars. For Vocalosporin, about $150,000 US dollars. In the subcutaneous format, so in other words, you don't have to go to an infusion center for belimumab, it's a little bit cheaper. For every year of life gained, life year gained, each of these drugs is over $100,000. And then they did a probability analysis of being cost effective, and this is 70% and 50% for belimumab and Vocalosporin. This is at a willingness to pay threshold from insurance of $150,000 per quality adjusted life year. And that's what people sort of do for rare diseases. But please understand that a lot of assumptions were made in this modeling, and these are some of them that I don't necessarily understand. Data from these trials were assumed to be sustained for at least 3 years. I would suggest to you that when we treat our patients, we want to see over that period of time more and more patients going into complete remission. If not, we're going to probably change the drugs. Treatment with each drug was assumed to be for 3 years unless adverse events occurred, and then the drugs were stopped, assumed at 1.5 years. Okay, so I don't think most people are going to use Vocalosporin for 3 years. Maybe for class 5, but probably not. Belimumab, maybe we want to use more long-term. And certainly, nobody would continue a drug for 1.5 years if the patient was having adverse events. Understand that modeling has to make assumptions. In this study, the CRR, complete renal response, and partial renal response were assumed to result in the same kidney failure-free survival. And I think I've shown you at the beginning that that isn't the case. And finally, quality of life measures were not reported in either of the trial. So the quality of life measures were extrapolated from the literature, patient interviews, and expert opinion. Not sure what applicability there is. So now I want to put this all together to round out this discussion. How do I suggest using the new therapies right now today? And please understand, this is my suggestion. This is based on as much evidence as I could put together. The evidence is not perfect. And as we get more experience with these medications, I'm sure this algorithm will change. But right now, let's start out with proliferative lupus nephritis because neither drug worked very well for class 5. Treat them with some intravenous methylprednisolone to get inflammation under control right now. Use a low, modest dose of prednisone and treat them as we would treat right now with a mycophenolate regimen or a urolupus regimen. Follow the patients very closely for the first 2 to 3 months. Look for their kidney function to be stable or better yet improved if it's not normal, and a decline in baseline proteinuria of at least 25%. Where do I get that from? Well, there's a lot of studies that look at markers of early response that suggest the patient's going to do well the way you're treating them later on. And this is coming from a post hoc analysis of the large ALMS trial that was done several years ago, comparing mycophenolate to cyclophosphamide in lupus nephritis. Do I think it's okay to add the new drugs, not from the beginning, but after a while? And my answer is yes. Go back to what I showed you about vocalosporin in patients who were exposed or not exposed to mycophenolate. It showed that the mycophenolate exposed patients actually did better than the patients who were naive. And in the belimumab trial, the relapsed patients did better than the new onset patients. One interpretation of those data is that these drugs will work better in somebody who already has some experience with immunosuppression. So if you reach these metrics after 2 or 3 months, continue what you're doing. You're probably going to do okay. If you don't reach these metrics, then consider adding belimumab or a calcineurin inhibitor. Now, I've written calcineurin inhibitor, not vocalosporin, because I don't know if this is accessible Vocalo is accessible in Egypt, but certainly in a lot of countries it isn't. But you still have to decide which one to use. Well, for both, I put a background of mycophenolate because this hasn't been tried in cyclophosphamide, and this didn't work very well in cyclophosphamide. If the patient has a lot of proteinuria, you probably don't want to go with belimumab. And the FDA has labeled that patients getting treated with vocalosporin should have a GFR, an eGFR of 45 or greater. Now, all of us are nephrologists, so we know we can potentially use the drug safely in lesser GFRs. We just have to watch the patient closely for development of acute kidney insufficiency. Again, watch the patient for 2 to 3 months. Apply the same metrics. If the patient is meeting these metrics, well, they're likely going to do well, so continue therapy. If the patient is not meeting these metrics, a couple of things. You have to verify adherence. If the patients are taking their medication, then maybe you have to start thinking about resistant disease. I think this is the minority of reasons for why people don't respond to therapy. The majority is because they don't take the medication. So are we done now? We have finally gotten 2 drugs approved for lupus nephritis, and this is my last slide. No, we're not done. In both vocalosporin and the Bliss LN trial, over 50% of the patients did not achieve a complete renal response or a partial renal response. And I've put here 6 months, 12 months, and 24 months for the placebo arm of trials and the drug arm of trials. I've added the Obinutuzumab trial. I know I didn't discuss it, but many of you are aware. This is a very potent rituximab-like drug against B cells, and it had a very good phase 2 trial and is now in phase 3. And you can see that the complete response rate in none of these drug treatments is over 50% at any time point. And remember, at the beginning I showed you, achieving partial response is not optimal for our patients. We really want complete response. And so the good news is that we're not done. There's a lot of medications being studied for lupus nephritis. I've made a partial list here from clinicaltrials.gov. If you don't see your favorite drug, I'm sorry, but I just wanted to give sort of a spectrum or a taste of what's out there. We have complement inhibitors that are being tried, interferon antagonists, cytokine antagonists, immunoproteasome antagonists, and small molecules. So we have a whole bunch of drugs that are being tested now, and I suspect some of these will provide benefit. So I think I'm done. I will stop sharing my screen, and I'm happy to entertain questions. However, we're going to do the symposium.
Dr. Rovin, thank you so much for that fantastic presentation. That was really very nice, digging into the granularity of the studies. I've been monitoring the chat, and there were a few questions that came up. Dr. Sabri, I don't know if you want me to go through that, if we have a few minutes.
Yeah, please.
And Dr. Rovin, you did address some of the questions, but there are a couple that maybe I could reflect to you as well. Coming back to the nephrotoxicity or lack thereof of vocalosporin, in the in the Vocalosporin trial, the average GFR was about 95 to 100%, and obviously measuring eGFR based on creatinine in that range is incredibly insensitive. So my question to you, and you did mention that the recommendations are maybe to be very careful if the GFR is less than 45. What is your personal, level of comfort when it comes to calcineurin inhibitors? If we have a choice between a calcineurin inhibitor and none, where do you draw your personal line?
Yeah. So a couple of things. You're quite right. I want to tell the audience though that one of the things we insisted on when we designed this trial was that we try to get some repeat biopsies in patients at least after the first year of therapy with vocalosporin. And I'm happy to report that we did. We're analyzing those data. We're going to report those data. And the idea is, did any of these patients start to develop or look like they're developing calcineurin nephrotoxicity? So I hope to be able to answer some of these questions a little bit better down the road. Okay, so that's one point. The second point is you're quite right. In my own practice, and of course, prior to Vocalo, which I'm just gaining experience with now in the clinic, we would use tacrolimus or cyclosporin. And, you know, I sort of, if the eGFR was below 30, I would start to worry a little bit about adding a calcineurin inhibitor. But if the eGFR was 30 or above, I often would add a calcineurin inhibitor in a proteinuric patient that wasn't quite responding to a mycophenolate, for example, a mycophenolate regimen. And, you know, I watch the patient closely. I will tolerate an increase in the serum creatinine of about 30%. And if it continues to go up, I cut back or stop it. And I have, in general, doing that, watching the patient closely, we've not had anyone slide off into ESKD. You know, so you have to have some comfort with the calcineurin inhibitors. I think the level of an eGFR greater than 45 was mandated by the FDA because it's likely everyone's going to use these drugs, and that would provide some guideline. But under a good nephrology follow-up, I think we can be a little bit more liberal with our use and be safe. You know, as long as we keep an eye on the patient. So I'm comfortable with that.
Another question that came up, and I'm paraphrasing here a little bit, is with regards to monitoring patients on biologics. And the question was about CD19 and immunoglobulin level. So, you know, we do know that rituximab does cause or can cause hypogammaglobulinemia, but so does belimumab. How do you use immunoglobulin monitoring in your practice? Do you use it, and how do you use it?
I use it, so when I do immunoglobulin monitoring, and the propensity is much greater with Ritux, as you know, and repeated doses of Ritux over time. So I usually, when I do rituximab, I start with quantitative immunoglobulins, and then I follow them probably once a year to see how I'm doing. Obviously, I'll get them right away if there's an infectious complication. I think that you know, a lot of patients with lupus have robust immunoglobulin levels to start with until you start treating them, and then of course they go down. They tolerate that pretty well most of the time. I really get antsy when the total IgG is below 400, and in some of my longer-term rituximab patients, I do give them intravenous immunoglobulin. Haven't run into that problem with belimumab, but my experience is vastly less than rituximab. I do monitor B cells, if that was part of the question, especially with rituximab, because if you remember, the LUNAR trial with rituximab didn't work. But when we did a post hoc analysis of the LUNAR trial, it actually looked pretty good in those patients who had B-cell depletion. And so part of the advantage of obinutuzumab, for example, is that it's a much more robust B-cell depleter, and the B-cells stay depleted for a long time. So sometimes when a rituximab response is not happening, I will check B-cells to see if they need a little bit more. So I do sort of monitor these things as safety measures.
Do we have a time for another question, or?
If you allow me, Professor Patrick, I have a short question. Professor Ruben, thank you very much for this comprehensive presentation. But it seems that we didn't have the magic bullet for the treatment of lupus nephritis.
The magic bullet for no, yeah, we don't.
Yeah, we're still far from this.
Yes.
My first comment on the use of vocalosporin. This is a multi-target therapy, and as you know, the multi-target therapy is commonly used in the Far East. And this is a good news that the multi-target therapy can still induce high remission in plaque and in other species. My comment is on the use of belimumab. There is some case reports of flaring of lupus nephritis and occurrence of lupus nephritis in patients receiving belimumab for extra-renal lupus activity. So how can you explain this?
Yeah, that's a really sticky question. What Dr. Sabre is talking about is we've started to see some reports of new onset lupus nephritis in patients with extrarenal lupus who have not had it before, who had been treated with belimumab. The actual incidence of this seems to be rather low. I will tell you, I'm working with a colleague in Europe that we're gathering all of the data that we can from all of the GSK trials to see if we can pinpoint a better incidence. That's a real sort of weird question, right? Which is, how is it that a drug can help in one setting and cause disease in another, or if it causes disease, what's the mechanism of that? I don't know the answer to that mechanism. I guess one of the things I would think about is there's probably a balance somewhere of B regulatory cells and B effector cells. And in some patients, maybe that gets really out of whack with belimumab, and maybe belimumab is knocking off or really inhibiting the B regulatory cells in those patients, or they start out with a low level of B regs and it goes away. I think that's sort of I'm making it up. You understand that I'm making it up. I have no data on this. I'm trying to explain something that is very difficult to explain. But I think that these data are trying to tell us something. And if we're smart, we're going to look at these patients and try and understand in what type of patient does this happen, because I think that's going to give us clues as to why lupus develops in general, or some of the variations in the pathogenesis of lupus. So I didn't exactly answer your question. I think the bottom line of your question is people have to be aware of that, because if you start seeing things go south, that's an American expression, if things get bad on belimumab, you need to think about stopping it. And this actually came up recently. We got a new lupus nephritis in our pathology conference in a patient who had lupus being treated with belimumab, and my first recommendation was to stop the belimumab. So I think nephrologists have to be aware of that.
Thank you very much.
Dr. Ruven, good afternoon.
Hello?
Yes, Dr. Ruven?
Yes, I'm here. Yeah, I hear you.
This is Dr. Ahmed Abdelwahab speaking.
Yes.
In your elegant presentation, you mentioned that when we use belimumab, regarding in the remission or regression of proteinuria, I think, and in lupus nephritis flares, it shows efficacy in people who had basically been immune suppressed with mycophenolate mofetil.
Yes.
It gave response better in those receiving MMF.
Yes.
Can we understand that it's better to use MMF than cyclophosphamide?
That is the way I'm pursuing it. That's correct. I would add both of these medications to a background of mycophenolate. I think the data support that, and some of the criticism of the way that the trial was done was that investigators might have picked cyclophosphamide for those patients who were sicker. I'm not sure that's true. For example, my group uses cyclophosphamide more often than mycophenolate for everyone. Okay, low dose cyclophosphamide, Lupus cyclophosphamide, because it's way less toxic. And so whether the patient was sick or not, and I think that's really the case. We haven't been able to show that the reason cyclophosphamide plus belimumab didn't work very well was because the patients were sicker. Now, is it because cyclophosphamide and belimumab have too much in common and it's not really adding anything? I don't know. But to answer your question directly, I would use both of these new medications on a background of mycophenolate.
Thank you, Professor. Thank you very much.
Just a last question. I know that are a little bit behind. Very, very nice presentation, Brad. So the studies tells you what the patient is going to, they are going to respond or not on the medicine. What about off the medicine? For how long you're going to keep the medicine, and how does patient do after you stop, off the medicine?
So, okay, that's the $1 million question, right? And I got to tell you, we don't have any data on that. The Bliss LN trial went another 6 months on belimumab, and everybody who was off belimumab got belimumab, so that doesn't answer your question. And the Vocalosporin trial went 2 more years on vocalosporin. I had nothing to do with that design. I probably would have stopped the vocalosporin. I'd want to see what happens. Okay, now to answer your question, I think we're going to use these drugs completely differently than anything that's been written here that I just showed you. I want to use these drugs together. I want to get rid of these overall immunosuppressants like cyclophosphamide and mycophenolate. And I can visualize.
She's not herself.
Somebody has their phone on or something.
Please, someone mute your phone.
Okay, so I want to. Right now, what my thinking is we bring all these drugs in, vocalosporin, steroids, and belimumab right at the beginning. Steroids get rid of inflammation right away. Vocalosporin we add on for the first year or maybe even less. Protect the podocytes, get the proteinuria under control, inhibit the T cells. The B cell drugs take a little while to work. Put belimumab on board, and what belimumab is doing, mostly in my opinion, is not inducing remission per se, but it helps to maintain kidney function and prevent flares over time. I think we're going to use vocalosporin short term. I think we could use belimumab long term. We know it's safe in non-renal lupus, and if that keeps flares away, then we've really accomplished something important in lupus nephritis, because the more they flare, more a patient flares, the more chronic damage they acquire.
Thank you so much.
Along these lines, there's a suggested or a hypothesis that belimumab may prevent the return of autoreactive memory B cells. So that might be a mechanism of prevention of relapse with long-term use. This is being tested in a completely different setting with membranous nephropathy, for example.
All right.
Okay, thank you, Dr. Roven, for your elegant presentation. I think we all have gathered many information from it. Inshallah, we are going to move to our next speaker, Dr. Shaima Abdeljalil, one of our elegant assistant lecturers. She is going to present a case of resistant lupus nephritis. Please, Shaima, share your screen.
Yes.
Go
Is it? Yes.
Go
Thank
on.
you, Dr. Ahmed. Good afternoon, everyone. It's my pleasure and honor to be with you today introducing our case of lupus nephritis. It's about 22-year-old female colleague student, Mansoura, single, with no special habits of medical importance and also free menstrual history. Her medical condition started since the end of 2016 when she complained of abdominal pain, nausea, vomiting, fatigue, and low-grade fever. She was admitted at ICU at hospital in Cairo for 1 week. Investigations revealed high serum creatinine, +1 proteinuria, and microhematuria in urine analysis. Albumin creatinine ratio was high, positive serology for lupus as ANA, anti-double-stranded DNA, lupus anticoagulant. C3 and C4 were consumed. Abdominal and pelvic ultrasound was normal except for mild ascites. So according to these data, she was diagnosed as active systemic lupus with lupus nephritis, and the first renal biopsy was done at February 2017. Light microscopic examination of previously processed and stained to small cores of needle biopsy revealed 17 glomeruli. 6 glomeruli showed endocapillary hypercellularity. 1 glomerulus showed cellular crescent, and 2 glomeruli showed sclerotic nodules. Tubules, interstitium, arteries, and arterioles were normal. Immune fluorescence examination revealed the full house pattern as shown here: mesangial and glomerular basement membrane deposits of IgG, C3, C1q, fibrinogen, scanty IgA, and IgM. So light microscopic and immune fluorescence findings are compatible with lupus nephritis class 4 activity index 7 on 24 and chronicity index 1 on 12. And according to these data, patient received pulse steroid 500 milligram methylprednisolone for 5 days, then high dose oral steroid 60 milligram prednisolone for 2 months, then underwent gradual taper of steroid dose, in addition to 6 doses of cyclophosphamide 500 milligram every 2 weeks as an initial therapy. Then she was maintained on low-dose steroid as 10 milligram prednisolone per day, mycophenolic acid analogs, MMF as Celsep 2 gram, shifted to equivalent dose of sodium chelated mycophenolate 7 months after due to severe gastric upset resistant to conventional treatment, in addition to hydroxychloroquine 400 milligram per day. And the patient was okay till October 2021. Here, the investigations 3 months before that event, basal serum creatinine was 0.5 milligram per deciliter. Albumin creatinine ratio was 87.6 milligram per gram. Anti-double-stranded DNA was negative. C3 and C4 were within normal ranges. At October 2021, patient became fatigued with low-grade fever, generalized bone aches, and decreased oral intake. Investigations then revealed +2 proteinuria and hematuria in urine analysis. 24-hour urinary protein raised to 2 gram per day. Serum creatinine raised to 0.8 milligram per deciliter. Anti-double-stranded DNA was positive. So the patient was diagnosed then as being in relapse, and she received their empirical pulse steroid 1 gram methylprednisolone for 3 days, then continued on 30 milligram prednisolone in addition to 2 doses of cyclophosphamide 1 gram every month for 2 months. Then cyclophosphamide was stopped as patient developed severe leukopenia. Here, the investigations after the second cyclophosphamide dose, CBC showed severe leukopenia in addition to normocytic normochromic anemia. Serum creatinine still rising to 1.8 milligram per deciliter. 24-hour urinary protein is still high, about 2.5 grams per day. Anti-double-stranded DNA was positive, C4 consumed, serum albumin was low, and ESR was high. So, second renal biopsy was done at January 2022. Light microscopic examination revealed the 25 glomeruli. 2 glomeruli were globally sclerosed. 13 glomeruli showed mild to moderate capillary basement membrane thickening by subendothelial hyaline deposits with intracapillary hyaline thrombi, endocapillary hypercellularity, and few intracapillary neutrophils, and 5 glomeruli showed cellular crescent. 4 glomeruli showed fibrous crescent. Tubules showed mild atrophy. Interstitium showed diffuse mild lymphocytic infiltration on top of mild fibrosis. Immune fluorescence examination revealed the full house pattern again as shown here, mesangial and glomerular basement membrane deposits of IgA, IgG, C3, and C1q. So light microscopic and the immune fluorescence findings are compatible with lupus nephritis class 4, activity index 11 on 24, and chronicity index 4 on 12. Patient presented to our unit after second renal biopsy with grade 3 edema and periorbital edema. She was hypertensive. And after improvement of cyclophosphamide-induced leukopenia, she received high-dose steroid, 60 mg prednisolone per day, in addition to 2 doses of rituximab, 500 mg per week, with mycophenolate sodium as myfortic 360 mg thrice daily, with hydroxychloroquine 400 mg per day, in addition to diuretics, IV human albumin, and antihypertensive drugs. But unfortunately, after secondary rituximab dose, patient developed fever and chest infection. Non-contrast CT chest revealed multiple bilateral scattered patchy areas of consolidation and ground glass opacity. And the findings were suggestive of COVID-19 Corat 5 category. Twice nasopharyngeal swab were done, and the PCR for COVID-19 was negative. After improvement of chest infection, patient received the third rituximab dose, but clinically she had grade 4 edema, marked ascites, severe subcutaneous edema, and face swelling with oliguria. Investigations after third rituximab dose revealed pancytopenia, urine analysis with +3 proteinuria and microhematuria. Serum creatinine is still rising to 2.6 mg per deciliter. Estimated GFR was 76 milli per minute. Serum albumin was low, and the anti-double-stranded DNA is still positive with high titer. Non-contrast CT chest revealed bilateral mild to moderate pleural effusion, and abdominal cuts showed marked ascites. And the patient received the cyclosporin in the form of neural 100 mg per day, together with high-dose steroids, 60 mg prednisolone per day, and myfortic with human albumin and IV diuretics. During the follow-up,
please mute your phones. Please mute your phones. Participants, please mute your phones. Go on, Shayma.
Yes. During the follow-up, patient didn't improve on diuretics. Edema was severe and progressive with marked ascites and subcutaneous edema, with progressive dyspnea and tachypnea, high central venous pressure. Urine output wasn't sufficient, about 600 to 800 centi per day, despite high diuretic dose, with uncontrolled hypertension, so neural was stopped then. So according to this data, patient underwent daily ultrafiltration about 4 liters per day with progressive deterioration of general condition. So it is a case of resistant lupus nephritis, underwent medical treatment with pulse steroid, 2 doses of cyclophosphamide, 2 grams, MMF, 3 doses of rituximab and cyclosporin without achieving remission. The question here, how can we deal with such a patient? And thank you.
Could I ask a question?
Yes, Professor.
So it seems like for many years, she had responded to her initial therapy, and then she relapsed badly, obviously badly. Yes. Did she stop taking her medications prior to the relapse, or did she relapse with all the medications on board?
Patient was on all medication, and the investigation were done every 3 months, and it was normal before that relapse.
Wow.
Yes.
Well, you know, that's really remarkable. I think that, you know, if she relapsed and was taking her mycophenolate and her hydroxychloroquine, you know, to the degree that you've shown us, you right away have to worry that this is going to be a problem going forward. And I agree with having tried cyclophosphamide. That sounds like it was a good idea. Now, I'm a little, and it's hard to sort out, I'm a little confused as to whether the cyclophosphamide caused the pancytopenia or the lupus itself. And that's always a little bit of a problem because she was not, you know, so the way I would have approached it is just about like you would have done. I would have probably gone immediately to cyclophosphamide, and I would have tried to give her a full course. Now, she didn't get a full course. She got a couple of grams. And it's a little bit hard to believe that she became pancytopenic from just 2 doses of cyclophosphamide. And of course, I don't know her. She's a little person. Maybe this was a big dose. You know, there's all these things. But if she really was intolerant of cyclophosphamide and she relapsed this badly on mycophenolate, then your options become very limited with very, very poor data. So I'm going to say this, but I'm not saying it with conviction. The next drug will be rituximab. And why is that? Well, you did it. I mean, everything you did was right. I mean, the rituximab seems to be the drug that we have the most data on for severe refractory lupus nephritis, taking into consideration that no trial was done very well. A lot of this is anecdotal, okay? A lot of it's uncontrolled, different background therapies, different doses of rituximab, et cetera, et cetera. However, there's been a number of studies such that there's at least 2 meta-analyses which suggest adding rituximab onto refractory lupus nephritis may be helpful. Okay, so that sort of slide.
Professor Ruben, please unmute yourself.
هو Professor is not hearing us.
Okay.
I got it.
Okay.
So
yes.
everything I just said is you didn't hear?
We heard most of it, sir.
Okay, all right.
The last sentence.
Okay, I don't know how it muted. I didn't touch anything. Okay, so anyway, it looks like the rituximab wasn't working. So a couple of things. One, I would have for sure checked her B cell levels to see if I was getting depletion of the B cells. I would have checked her quantitative immunoglobulins, just like we were talking about with Patrick earlier, to see what sort of infection risk I'm putting her at. Now, if her B cells were truly depleted and you have nothing happening that's good, okay, this patient's in real trouble. When you then look at all of the drugs that are tried for refractory lupus nephritis, there's almost no good data. So I'll throw out a couple of examples. One is laflutamide. I've been using laflutamide in patients who have bone marrow suppression from mycophenolate. It doesn't suppress the bone marrow. It seems to be okay. I've never used it in refractory disease, but some people have. with some benefit. So I don't know if you have that in your country, but that would be one option. The other option that I think is much more palatable, in my opinion, is, and you noticed as she was going along, her anti-double-stranded DNA antibodies were continuing to go up very much, right? They were really increasing. So I might have tried to inhibit her plasma cells using either bortezomib or, which is a little bit risky, or a plasma cell antibody, a CD38, and then follow it up with rituximab. But at this point, you're in big trouble. She's in big trouble.
Brad, can I put on the table another option?
Yes.
Can we just, this patient probably is resistant to most of the therapies, the last relapse she had by the end of 2021. When do we think we can just try to taper down the medication, put her on dialysis, do, aggressive UF and adequate dialysis? And where is the fine line, to just try to taper off the immunosuppression? Are we going to think all the time by, in escalating, not de-escalating the immunosuppressive therapy?
Yeah, it's a very good question, which is when do you stop and when do you push? So, this is with the idea that, she could get a transplant in the future. I'm assuming that's true. So why would I have been aggressive with this patient? This is a very young person, prime of her life, so to speak. And the kidney biopsy to me was pretty impressive for severe inflammatory disease that might actually have been, that should be remedial to some sort of therapy. And I realized between biopsy 1 and biopsy 2, she developed 2 sclerotic glomeruli, a little bit unusual in a 20-something-year-old. And I don't know about her IFTA, if that was able to be calculated, because she had quite a bit of interstitial inflammation, so that might be hard to read. But so to answer your question, I would look at this on an individual case basis, and I always find that the kidney biopsy is very helpful. If this patient had 50-60% glomerulosclerosis, and this patient had, considerable IFTA over 50%, then I might say, well, in this time of COVID, I'm immunosuppressing the heck out of her, and I'm not going to get much back. Then I might back off.
Professor Braid, please, IFTA was about 15%.
Okay, so not terrible. So in this particular case, I would have been very aggressive with this patient. And it's exactly as you said, which is what we tend to do is pile on immunosuppression, hoping something's going to work. So what I'm saying is we have to think through this. And the first thing is get rid of mycophenolate, because clearly she didn't do well with that. And then you have to try and understand if the cyclophosphamide could have been continued because this was a pancytopenia from the lupus, or this was because of the cyclophosphamide. I don't know the answer to that question. If that didn't work, then I would put in rituximab, but before doing the rituximab, I would measure her quantitative immunoglobulins to see exactly how immunosuppressed she was. And I would have supplied her with intravenous immunoglobulin if that was very low. Would that have not interrupted her rituximab course? Maybe, I don't know, because she developed the pneumonia. Now, you've done a lot of things, but you haven't had a response to anything, and she's declining. So we could do, and I don't know how many months went by, we could do another biopsy to see if it's worth really pushing the immunosuppression. And you could say, well, I just did a biopsy 6 months ago. Why would I do another one? Well, with that degree of inflammation and the starting of fibrocellular crescents and the lack of control of the disease overall, right? she may have really knocked out her kidney by this point, and you're absolutely right. Stop, dialyze, get her transplanted. On the other hand, if the biopsy still showed a lot of cellular lesions, and you know the B cells are active because her anti-double-stranded DNA is going crazy, then I still think I would have done one more thing. Now, I haven't been paying attention to the chat. I saw a whole bunch of stuff come through, CAR T cells. There's a whole bunch of things in a list. We just wrote a review article on refractory lupus nephritis in arthritis and rheumatology. You guys can take a look at that. The data for any of those things is very limited. People are trying to study them. I don't know the answer to that. I know that there's been one case report. People are interested in these sorts of things. But whoever asked me that, you do have to balance not killing the patient with immunosuppression practically. So again, this is what I would have done with a young, otherwise healthy person. I would push as much as I could, and then I would back off if I feel like I'm harming her. An older person, a person with more chronic damage on the kidney, back off, and frequent use of the repeat biopsy can be very, very helpful.
Another question, sir, from the panel, from our participants is, was there a value for plasma exchange?
Well, you know, the data on plasma exchange, this was tested many, many years ago in severe lupus nephritis by the Rush group and the Collaborative study group in the United States. And, you know, I thought they provided fairly definitive data that plasmapheresis was not beneficial. You know, I know we sometimes use plasmapheresis in ANCA vasculitis, and, you know, maybe Patrick wants to weigh in a little bit on that. But I would not have used plasma exchange personally.
So what about vocalosporin and belimumab?
Yeah. So what the point we make in that review article is that neither vocalosporin nor belimumab have been tested in this situation. Could they work? Maybe, but that would not. So I would say belimumab would not be for an aggressive disease like this, and vocalosporin might help with the proteinuria, but right now, the way her serologies are going, I'm really worried about her B cell axis and her plasma cells. So that's the way I'm thinking about this disease.
There is an interesting review article which is shared by Dr. Asahar, which is an approach to refractory lupus nephritis. I advise the audience to read it in full. Thanks.
That's a Brad Roven article that he was mentioning.
Yes.
Too.
Yeah.
Yes.
Swati Arora and Brad
Yes,
Roven.
Professor Roven article, yes.
I didn't read the authors. Thank you.
Dr. Roven,
Yes.
do you want to comment on the Calibrate trial?
Yes. Oh, do I want to comment on it?
Yes.
It was done badly. Very, very, very
You were
bad.
part of it.
What?
Weren't you part of it?
We were, but it was still done badly.
And I don't know that that applies to this, but it does raise the. I mean, first of all, I really appreciate your comments, notably about leukopenia in the setting of lupus and lupus nephritis, and it's very nerve-wracking because you have to try and weave your way through leukopenia. Is it your drugs or is it the disease? But the Calibrate study did take a multifaceted approach, and I realize this does not apply directly to a case of very refractory lupus, but is this an approach to severe disease of, and maybe you can describe that combination.
Yeah, so what Patrick's talking about is we did a study in the United States through the Immune Tolerance Network called Calibrate. And the idea is the following. If you kill B cells by whatever drug you're using, and it could be cyclophosphamide, mycophenolate, rituximab, immediately levels of the B cell activating factor Bliss go up, okay? And they get very high. And one of the things that we thought about with the LUNAR trial was we killed the B cells with rituximab, and then the B cells start to recover in a high BAFF environment. That B cell recovery in that growth factor environment tends to stimulate autoreactive B cells, okay? And so it could potentially make things worse, my opinion, account for relapsing. So the Calibrate trial was designed to ask that question, sort of. They really put together, the immunosuppressive regimen was a little bit bizarre. It was 2 doses of cyclophosphamide plus rituximab, followed by belimumab, okay? So the idea was, would the addition of belimumab after 2 good drugs that kill B cells help in remission? And frankly, that concept is, in my opinion, wrong. That idea is not to necessarily help in remission. That would, I think, help in preventing relapses. But I think what Patrick is asking is a more important question, which is, if we think about the pathogenesis of lupus and lupus nephritis, and we start with the fact that we have autoantibodies, we're not very good at getting rid of autoantibodies quickly. The things that get rid of autoantibodies quickly are things that kill the plasma cell. And so in some review article I wrote a couple years ago, I had this sort of idea that we would start therapy with a plasma cell drug, kill the autoreactive plasma cells along with other plasma cells, come back in with rituximab to kill the cells that are supplying the plasma cells, and then maintain the patient with belimumab to sort of not let autoreactive B cells come back into the circulation. So, maybe that was sort of laughable. Maybe you'd never have another immunoglobulin in your life made, but I suspect that B cells will come. And I think that this is the idea, is to try and address the mechanisms that we think are actually playing a role in that particular patient's lupus. And we're not very good at that, by the way, right? We treat everyone the same way. And I think as we're getting more and more of these drugs, we may be able to start to figure out how to individualize treatment. But yeah, so that would be how it sort of answered that question, Patrick.
Thank you very much. Really very, very interesting discussion, but we are a little bit short of time, so we should move to the next speaker, please.
Good evening, everyone. I would like to present Professor. Hi, my name is Dina Shaheen. I am a professor of rheumatology and immunology, Mansoura University. I would like to thank Professor Ala and my colleague, Professor Amr Al-Husseini, to attend this interesting meeting. Actually, I have a couple questions for the previous lectures. One for Professor Rovin. What about the use of JAK inhibitor in this patient? This is extremely resistant. Tried every accessible modality for treatment with no response. And I think she is actually lupus activity all over, hematological. Maybe the CT chest was not a COVID, especially the swab was negative twice. Maybe pneumonitis, resistant lupus nephritis.
Yeah, good idea.
Yes, I think it is a very active systemic lupus, not only lupus nephritis. So what about the use of JAK inhibitor, baricitinib, for example? seems to be affecting costimulatory inhibitory for the effector T cell, blocking the immune cascade from the start upstream. So what about the use of this?
Yeah, I can't, honestly, I have no experience. I know it's being investigated, right? So I don't want to comment because I don't have experience, but I certainly, if I was working with you and you knew a lot about it, we would work together on it. And I think that's the other thing. I'll just say,
we actually know about it well in rheumatoid arthritis, but it seems to be promising. Yes, in lupus, it's some studies promising maybe, but I think this patient has no hope. Has no other hope.
And so I guess maybe my last comment, because I'm sure the other speaker wants to talk, is whenever we have these really difficult cases, we work together with rheumatology. We have a combined clinic. And I think it's really important because the brain power of both specialties should work together in these sort of very difficult patients. I think that's the way we do it.
And we also, as rheumatologists, we prefer to use the high dose of rituximab. That's meaning 1 gram, 2 doses, 15 days apart. And I think the patient used lower dose, maybe half gram.
Yeah,
that's, I think this is very low dose. I don't know why.
Well, that's why I said, you probably, before you say rituximab didn't work, you need to see what the B cells are doing, because that was a low dose.
So what about adding tacrolimus instead of cyclosporin to MMF or cyclophosphamide in this patient?
Certainly doable. I wouldn't use mycophenolate. I think she's proven mycophenolate.
Personally, I prefer cyclophosphamide over MMF. And good results, especially in lupus nephritis and in resistant difficult cases. He's, to my opinion, he's way better.
No, you're talking to the choir here. I do the same thing. I'm a very much cyclophosphamide person, but most of the world isn't.
Yes. Okay, thank you, Shaima, and thank you for the panel. I would like to introduce the next speaker, Professor Siddiq Ahmed, Professor of Nephrology, Kentucky University. Please go on.
Yes, good evening, everybody. Hopefully it will be short and less complex than the previous talk. It's getting late, so let me share the slides. Give me a second. All right, I'm in Lexington, Kentucky with Dr. Amr El-Husseini. And the topic I will be discussing today is the role of plasma exchange in Rpgn and vasculitis. So as I'm sure over yesterday and today, other speakers have discussed the concept of rapidly progressive glomerulonephritis, very rapid loss of renal function, along with the symptoms of acute nephritis, and kidney biopsy showing acute inflammatory glomerular lesions with crescentic GN. And these are due to a response to a ruptured glome and the severe marker of injury. So this is happening in our population, in our patient population, but I think a little bit of pathologic perspective will be helpful. As you know, any inflammatory glomerular injury can cause crescentic GN or Rpgn, but the mechanism is different in different types of rapidly progressive glomerulonephritis. As you can see in immune complex GN, such as IgA or lupus, we were discussing, there is lots of immunoglobulin and complements if you look at the biopsy in the capillary wall. In the contrary, in anti-GBM disease, you will be seeing just a linear, nice pattern of IgG, which is pathologically very different. And in some aspects, like C3 glomerulonephritis, you will just see complements. And interestingly, in ANCA vasculitis, you will not see any of those in the capillary wall, because basically things are happening at the level of neutrophils. They get primed and activated, and alternate pathways are activated, and then you're getting the capillary injury indirectly. So with this concept, we want to move on and look at our patients who present with rapidly progressive glomerulonephritis and crescentic GN. We all know some forms of GN are more likely to have this crescentic GN, and such as anti-GBM disease and ANCA vasculitis. On the other hand, the immune complex nephritis such as lupus, IgA, C3 nephritis, post-infectious, their presentation is rather very in a wide spectrum. A small majority of their patients, a small number of the patients presents as crescentic GN. Most of them, we see them as not rapidly progressive glomerulonephritis. So this is from by Diagadi and Charles Jeanette in the pathology text. Very nice. You can see that most of the time when we are dealing with crescentic GN, we are dealing with anti-GBM and ANCA vasculitic patients. So therapeutic plasma exchange, we are considering in this setting, in this kind of patient. And why do we consider this? The molecules or the immunoglobulins which are causing these injuries, like immune complexes, they are pretty big molecules. You can try to suppress those by using immunosuppressants, all kind of immunosuppressant as you did for your previous patient, but it takes time. A immunoglobulin can be in the circulation for 21 days. So whatever medication we use, a steroid or cyclophosphamide or rituximab, it is going to take time. And then the antibodies in the circulation are going to cause damage to the organ. And only way we could remove this is through plasma exchange. Conventional dialysis will not remove this. And there are two ways we do plasma exchange. One is a centrifugal separation, and another is membrane separation. In the United States, in our center, we do both, but most of the places will do a centrifugal plasma exchange. And Europe, actually, it is opposite. Japan and Germany and other European countries, membrane separation is more common than centrifugal plasma exchange. So as I mentioned in during my previous slide, that the circulating immunoglobulins can be there for a long time, and other conventional extracorporeal therapies will not be able to remove those. Our cutoff for dialysis is 15,000 Dalton, and also if you do hemofiltration, they go up to 30 to 40,000 Dalton. So plasma exchange comes in picture in this scenario if you're trying to remove these antibodies very rapidly. So how effective is plasma exchange in removing these antibodies? This is from Andrew Kaplan from University of Connecticut, his experiments in late 80s and early 90s. As you can see, if you remove 1.2 to 1.4 volume of plasma exchange in a given session, you can reduce the antibody levels almost between 65 to 70%. So very effective. But the problem is these IgGs are mostly extravascular. So if you remove them, they tend to come back. And so this is just, so you keep doing what you have to do. Like in this slide, we are showing that, again, this is from Dr. Andrew Kaplan. If you do one plasma exchange, the antibody levels goes down to 40%, but next day it bounces back. So you do another exchange, it comes back again, and do another exchange. So after 3 exchanges, there is a significant reduction of the baseline immunoglobulin levels. Another question we face is that, okay, you're removing these immunoglobulins, the complements, and the immune complexes with the plasma exchange, but you are using 2 different modalities. You're using a membrane separation technique, and you're also using centrifugal technique, are those equally effective? Especially in the United States, we are doing mostly centrifugal plasma exchange. So some centers which are not used to this membrane separation, they often ask this question. So the answer is yes, these are equally effective. There are multiple studies done, and when you do the membrane separation, you check the level of immunoglobulin in the plasma, and also you check it in the removed plasma. The sieving coefficient is 1. So it is 100% removed. And this study by Hafer from Germany, done a few years ago, he randomized 21 patients, and then he crossed over. He did both the centrifugal TPE and also membrane separation TPE, and found that they are equally effective. As you can see, the IgG reduction and IgM reduction are both very equal. One thing he found that in membrane separation, it may take a little longer, but the time is not that much of a difference. Centrifugal separation can be done within 1 hour or 1 hour 20 minutes time most of the time. But membrane separation in their study took like close to 2 hours or a little more than 2 hours. Anyway, so this is the context of the need for plasma exchange in certain situations where there are a lot of circulating antibodies, immune complexes, and complements. And then the first study showing the effectiveness, or I would say a case by Dr. Chris Lockwood. He's no longer with us, published in British Medical Journal in 1975. As you can see, this case with Goodpasture syndrome, he was started on cyclophosphamide and prednisone, and then his creatinine was going up, and he was started on dialysis, and then he started doing plasma exchanges, and gradually his anti-GBM titer is coming down, and he came off dialysis, and his creatinine improved. That was the first case, to my knowledge, published in an international journal. And following year in Lancet, his group came up with 7 patients, and they did plasma exchange. And as you can see in this, that the titers of anti-GBM nicely came down, and the patients did much better. Because this is a rare disease and the mortality rate is very, very high, there is no big randomized trial. But again, another British study, Dr. Levy from, I think, Imperial College of London, he looked at retrospectively the patients over the last 25 years before he published it in 2001, who had Goodpasture's syndrome and anti-GBM disease, and they were offered plasma exchange along with conventional therapy of steroid and cyclophosphamide, and how they did. So you're looking at the short-term outcomes, and as you can see, all patients who had creatinine less than 500, they did very well. They did very well, and the creatinine was more than 500, but not on dialysis, they also did somewhat good. But people who was on dialysis on presentation, they did not do well at all. And so that is also obvious nowadays when we see these patients with anti-GBM disease and Goodpasture syndrome. And the long-term data they had for 5 years. This is a retrospective analysis, and it showed the same. The outcome was worse for people who presented with severe renal failure on dialysis, and better who was not on dialysis. All these patients had kidney biopsies, and 60% of these patients had diffuse alveolar hemorrhage. So based on this, our approach for anti-GBM disease, based on KDIGO 2021 guideline, that along with cyclophosphamide and glucocorticoids, plasmapheresis in all patients, except those who are treated with dialysis at presentation, because that's kind of too late. Putting them on plasma exchange does not help unless they have diffuse alveolar hemorrhage, because that aspect can be helped with plasma exchange. And the way we do it, which is, I think, standard everywhere, this is nothing but repetition of a protocol, that we keep doing plasma exchange every day for 14 days at least. And also some centers will check the levels weekly to see if the titers are coming down. American Society for Apheresis has the same guideline. As you can see that if it is a category 1 indication, people who are dialysis free, that means the kidneys are still not that bad in the situation. And if you're dialysis dependent, then it is a category 3 indication. So which is not much of a benefit doing plasma exchange on these people. All right, so let's change gear now. So I think it is straightforward in anti-GBM disease and Good-Pasture syndrome, but what about ANCA? There's a lot of interesting talks and, I think controversies going on at this time after the publication of the Efficacy trial, but I like to go through a few basic facts before we go into more detailed discussion. ANCA, in the late 70s, 80s, initially was thought as just a biomarker. Well, people didn't think that this is itself causing the disease. But since then, and from multiple centers, we have this, published data that ANCAs can activate the leukocytes, and if you give a mice myeloperoxidase, antibody, they developed severe acute crescentic GN, and also there is a case report well known that ANCA going to the fetus from mother and causing a severe vasculitis and nephritis in the newborn. So this is pathogenic. So if it is pathogenic, then why not try to remove it and then see how the patient does. So that's what, so there were small studies, clusters of studies which did that. Some were not adequately powered. So there was people who were doing it thinking that it will be helpful. And then in 2007, by this study, the MEPEC study came, and Dr. Jain showed that he randomized patients, 137 patients with ANCA-associated systemic vasculitis with serum creatinine more than 500 micron-mole. These are severe renal failure patients. And he divided them into two sides. One side, half of the patient will get plasma exchange, and half of the patient will get IV methylprednisolone. And both groups received oral cyclophosphamide and oral prednisone. There is, this study on your face may ask you a question. When do we do plasma exchange and not give IV methylprednisolone? I would think it will be more practical. Is both of the group, both sides got the IV steroid, IV pulse steroid. But so in a way, the plasma exchange group, in my view, already weakened by not getting the IV pulses. But still, if you compare the results, you will see that out of these 137 patients, 70 the people who received the plasma exchange, no dialysis at 3 months were much less. TPE patient did much better. 69% were dialysis free, compared to the other group, which got IV steroids and cyclophosphamide. And then at 12 months, you also see that 19% of the patients were after TPE, where risk of ESRD was much less, and then the risk of ESRD was much higher in the group which did not get the plasma exchange. So TPE increased the rate of renal recovery in ANCA vasculitis that presented with renal failure compared to IV steroids, and so this was taken with a very positive way. It is true though that 1 year the patient mortality did not change, and also after 3 years or 4 years they did a secondary analysis. It did not show in the patient's change in patient's mortality, but in 1 year time and 3 months time, definitely it had a positive impact on the plasma exchange group. Okay, so that was the thought process, and then people thought that okay, we need a bigger trial and to test it out, because the jury is not sure which way to go. And then came Efficacy. So as you already know, this is common information now. 704 patients, half and half, 2 by 2 factorial mode. 300, half of the patient got plasma exchange, and half of the patient did not get in plasma exchange. And the plasma exchange people also were tested for low dose, reduced dose glucocorticoids compared to standard dose glucocorticoids. The same is true for the other arm, no plasma exchange. So we will not focus on that steroid dose because I think it is well accepted now that reduced dose glucocorticoid most of the time does as good as standard dose glucocorticoid in this disease. But we'll look at the patients who had plasma exchange and did not have the plasma exchange. How did they do? So this is what they find out. They've followed the patient up to 6 years. And even though you see a separation of this curve in 1 year, by the time 3 years, it kind of it diminishes. And then there is no really no difference. People who got the plasma exchange out of these 352 patients, and these are all patients who had a GFR less than 50. We know that how many of them had severe disease. I will show you in the next slide. But overall, it did not make any difference. So, but again, if you look harder, out of these 327 patients on the plasma exchange group and 336 patients on the non-plasma exchange group, people who had severe disease, the people who will benefit from plasma exchange are 100 in each group, and 66 on each around 60, and here is 70 in each group was on dialysis. So this is the only group in the previous studies which we found had some benefit. Let's see what happened to these patients, and do we have an analysis of these patients in this study? Now, MAPEX showed a difference in 3 months and 1 year, exactly where we are seeing this separation of this curve in the PEXIVA studies. Is it possible? This graph is showing many patients who had acute, 100 patients with acute renal dysfunction with many other 200 more, which does not have any severe disease. Because GFR of 50 and below 50, this is a disease mostly in the elderly population, which is not uncommon. And ANCA disease can be sometimes a very chronic and smoldering manifestation. People can have fibrosis, and then if you don't have any kidney biopsy to know who is who, and put them all together and try to see that it is making any difference or not, it may be misleading. So that's just the thought there, and many people think in the same way. So based on this, there was an editorial which was published in New England Journal following this study by Ron Falk from Chapel Hill and also Dr. Vimal Kadirabelli. And they question if the trial, they mentioned the trial has limitations because a kidney biopsy was not required for the entry. Did they have kidney biopsy? Yes. They did not have kidney biopsy on all 700 patients, but they had at least 300 to 400 kidney biopsies, but they did not analyze those biopsy and did not make a part of their study finding. So without baseline biopsy data, the proportion of the patients who had kidney dysfunction caused by active inflammation, which may respond to immunomodulatory therapy as compared with chronic sclerosis, which would not respond to this therapy, is unknown. A subgroup of patients with aggressive kidney disease with minimal scarring may benefit from plasma exchange. So, so that was their thought. And then, if you dig a little more, there was a letter written to the authors and asking what intensity of plasma exchange, how many exchanges were done, and the authors answered in this way. Out of 317 patients in plasma exchange group, 20 received between 1 and 6 exchanges. They could not tell exactly how many, 1 or 2 or 3, but we know that our standard approach is 6 treatments. So, and then 15 patients did not get any exchanges. And these were the patients on the TPE group. So if you add this number, 35 out of 317 was getting plasma exchange, 11% of the patient in the TPE group did not get full dose of TPE. That's a fact. Now, the question becomes more complicated. How many of these patients were on that group? Because there was only 101 patients in the renal failure group with creatinine of more than 5.7. So how many of these patients had reduced numbers of TPE treatments? Is it possible that all 35 in the patient, and I'm just guessing here, I don't know, I'm just asking the question, or is it 50-50? So these are possibilities. So what point I'm trying to make, are we able to make a judgment on those severely ill kidney failure patients based on this study or not? So if I compare head-to-head, MEPEX and PEXIVAS, if you look at the number of patients, 137 in MEPEX and 206, I'm talking about the severely ill patients, so orange to orange, apple to apple. In MEPEX, we see statistical benefit in 3 months for TPE, showing more patients off dialysis. But in PEXIVAS, despite there is clear separation on figures, there is no statistical assessment at 3 months. At 1 year, there's increased likelihood of being off dialysis. And in PEXIVAS, at 1 year, no statistical benefit, but provided figure is, it may be diluted with the patients having creatinine less than 5.7. We have renal biopsy data on the MEPEX. We don't have biopsy analysis in PEXIVAS. So what happened? So I'm sure that after the PEXIVAS, people are less thinking twice before doing plasma exchange on this patient. And we also see a change in the ASFA guideline. ASFA guideline, the most recent is 2019, and it was a category 1 indication if your creatinine is more than 5.7. But and if it is less than 5.7, it was category 3. Category 3 means there's no solid evidence to back it up. It is case to case up to the physician. But they changed it after the PEXIVAS. We see that they are now saying that it is a TPE if you have a creatinine of more than 5.7 is category 2. So anyway, that's what we saw. Also seeing this in the community. So in my view, role of TPE here is previous study shows benefit for TPE in patients with severe renal disease. PEXIVAS found no benefit of the TPE according to the PEXIVAS trial. Lack of renal biopsy data is a substantial deficiency in PEXIVAS. 35 patients in PLEX group did not get full dose of TPE. The effect of this under treatment is unknown and may be significant if a substantial number of these patients were in the group. 101 patients were with the severe renal disease. We have no way to know. So PEXIVAS data probably is not sufficient to negate the previous recommendation that TPE may benefit ANCA patients with severe renal disease. So that was the main thing, and then I will be touching on a few other vasculitis processes where TPE is helpful. One of them is Cryoglobulinic Vasculitis because it is becoming rare now because most of the patients were due to hepatitis C, and now we have good hepatitis C treatment. It can cause massive intratubular immune complex precipitation and small vessel vasculitis and Rpgn. We have all seen cases in our experience, and TPA could be very helpful because it is very effective in removing the cryoglobulins, and also it can restore the monocyte macrophage function, which is a more theoretical benefit. And before it, as it is removing the immune complexes, the microvascular circulation is more, so it helps the organ perfusion. So it has all kinds of benefits. But do we have any large randomized trial showing this? Probably not. I looked at this from a study, a retrospective study from Italy. They looked at their Italian hemophilesis database and looked at patients between 2005 and 2015. 159 patients. They categorized the patients after the plasma exchange, and these are all comers. Cryoglobulinic vasculitis. These are just not renal patients. They have multi-organ involvement. Most of the people had a very good response after plasma exchange, and again, this is an adjunctive treatment. It is not the main treatment because if you keep removing the cryoglobulins and they keep coming back, unless you stop producing them, it will not be helpful. And they looked at those patients long term also. People who got plasma exchange did much better than who did not get the plasma exchange. So what is the American Society for Apheresis guideline for TPE in cryoglobulinemia? This is a category 2, which means it is a second-line therapy. And where you need to do it is 3 to 8 procedures, plasma exchange procedures, and also there's a recommendation to keep the room warm because there are case reports where your plasma, the plasma has precipitated in the cold environment in the extracorporeal tubes in the machines. So that is about cryoglobulinic vasculitis. So, not every patient with Hep C and cryoglobulinemia or any other causes of cryoglobulinemia needs plasma exchange. The practical approach we have, we use in our clinical practice. If the patient has asymptomatic hematuria or proteinuria, and a stable creatinine, we just do antivirals. But if they become nephrotic, then we may need to consider rituximab or cyclophosphamide to stop production when the antivirals are working. But if you have a situation where there is a rapidly progressive deterioration, and if you biopsy show crescentic GN, or if you have a multi-organ involvement, pulmonary renal syndrome with hyperviscosity, yes, plasma exchange it should be beneficial, and we do it without any hesitation. Regarding the lupus, I think the previous the case was interesting. When the first case on anti-GBM and good pasture was published in British Medical Journal, that time in 70s, it was thought it could be plasma exchange could be a good treatment for lupus, and the small non-randomized case studies showed some benefits. So there was a large prospective study. It was published in New England Journal of Medicine in 1992 by the Lupus Nephritis Collaborative Study Group. They plasma exchanged the patients for 3 years, 3 times a week, and but the conclusion was treatment with plasmapheresis plus a standard regimen of prednisone cyclophosphamide therapy does not improve the clinical outcome in patients with systemic lupus erythematosus and severe nephritis as compared with the standard regimen alone. They had 40 patients in each group. They did those plasma exchange for 3 years, and most of the patient had class 3 and class 4 disease. Crescentic lupus was not part of that study. And as I mentioned, they look at the dialysis outcome, they look at the patient survivability, they look at the worsening of renal failure. In all 3 categories, there was no change between the standard and plasmapheresis. So this is class 3 and class 4. But if you ask me, the crescentic lupus nephritis or lupus along with catastrophic antiphospholipid syndrome or lupus along with the TTP, should we do plasma exchange or not? There is not enough studies, but conventionally we do. We do, especially if they are along with antiphospholipid catastrophic situation, or if the situation is along with TMA, thrombotic microangiopathy, there may be benefit of plasma exchange. So if you look at the ASFA guidelines, again, in 2016 for lupus nephritis, it was category 4. Category 4 in ASFA is actually not recommended. It may cause harm. But severe lupus, they are talking about systemic lupus, it is category 2. But if you look at on the bottom, the 2019, they took off this lupus nephritis. It is no longer there. They're just keeping the severe lupus, systemic lupus, and it is a category 2 indication as it was before. So to summarize all, my thoughts are TPE along with immunosuppression in anti-GBM disease and good pasture syndrome should be started early to prevent very high morbidity and mortality. TPE should be considered in ANCA vasculitis with severe renal disease and pulmonary hemorrhage. Rapid clearance of cryos from circulation by plasma exchange is helpful in the setting of Rpgn due to cryoglobulinemia, so it is a case-by-case basis. And there is not enough evidence to support the role of plasma exchange in immune complex crescentic GN such as lupus or IgA nephritis. With that, I want to end. Thank you very much for your patience.
Thank you, Professor Siddiq, for this illustrative and comprehensive presentation. And we would like to open the floor for discussion.
Thank you very much, Professor Sadiq. We are really very short of time, so if you can have one question from the moderator or from the audience, please.
I just want to add, of course, excellent presentation as usual, Sadiq. Just a quick comment about about plasma exchange, you have to be vigilant that many medications can be removed by plasma exchange. And we have to be consider the pharmacokinetics of medication, especially rituximab. I think if you are doing plasma exchange, you shouldn't do plasma exchange at least 2 or 3 days after giving rituximab, because the removal of rituximab is very high with plasma exchange in the first couple of days. If you agree with this.
Yes, very important point. Thank you for bringing it up, because we in our centers, as you know, we do not, at least 48 hours. We wait at least 48 hours. And of course, the recommendation is between 48 to 72 hours, because all these immunoglobulins, this is IgG, rituximab, it will be removed if you do a plasma exchange right after giving it. Did it happen by mistake? Yes, but sometimes we try to redose the patient if that happened. And also one thing I want to mention for cryoglobulinemia, sometimes when you feel like you are going to give this, rituximab, this is IgG. It can actually precipitate a crisis. So it may be better sometimes in a particular situation to do plasma exchange before you give rituximab or other suppressive therapy.
Professor Sadiq, just a short comment. All the RCT and the non-RCT trials which compare the plasma exchange versus no plasma exchange, or plasma exchange versus pulse methylprednisolone, they agreed and conclude that there is no effect on long-term mortality, there is no effect on the long-term incidence of end-stage renal disease, but there is a little bit of improvement on the short term. So how can you explain this?
That is a very good point, that we see the signal which indicates short-term benefit, but in the long run, that kind of fades away. I don't have a good explanation, but these are very sick patients. There are, it's not that particular disease, the other comorbidities, which probably fades away. But one way I think about it, even if I have a short, for example, if I could prevent dialysis for a year for a patient, that is a win for me. For 7 plasma exchange in the United States, in my center, is probably $14,000. But a patient on dialysis for a year, we're talking about $100,000, $130,000. So it is economically more beneficial if there is any benefit. It is also benefit to the patient if even they can get a short-term benefit compared to long-term. So that's a very good point. I don't know how to answer your question, actually.
Okay, thank you, Professor Sadiq, and for the audience, sorry being late, and we will move to the next speaker. Please, Professor Ala.
Okay, we will move to his presentation. A case will be presented by Sam Bevan, a fellow of nephrology from Kentucky University. Dr. Sam, please.
Absolutely. Can everyone hear me?
Yes, we can hear you.
And like Dr. Sabri said, I'm one of the fellows here at the University of Kentucky. I know it's getting late, so we can move through this case with some dispatch. But as Dr. Ahmed was just talking, this will be a case that kind of speaks to the role of when and how much plasma exchange to do in some of these complex vasculitis cases. So some basic background here. We'll start with a 65-year-old woman initially presented to an outside emergency department with complaints of progressive dyspnea. Showed up actually a couple of times with similar complaints, was initially treated for a pneumonia with antibiotics, then represented shortly prior to transfer here with worsening respiratory symptoms and lab showing a dramatic AKI. This is her initial chest x-ray when she showed up at the outside ED. Given all this, she was initially admitted to the outside hospital and then transferred to the University of Kentucky here for further workup. Just a little bit of background on her. Really not the healthiest person in the world, but not any dramatic past medical history. Carries a diagnosis of high blood pressure, but not on medications. On a statin, some thyroid replacement. And really the most dramatic thing in her past medical history is a couple of different abdominal surgeries, first a hernia repair, then some further repair and mesh resection for complications related to that. But on the whole, a fairly healthy, functional person immediately prior to the onset of these symptoms. Quick look at her medication list. Nothing too dramatic on here. Said some thyroid replacement, some Celexa, SSRI, thyroid medication, and then some pain medications, perhaps Meloxicam, the only objectionable thing there from a nephrology standpoint, but nothing that really catches the eye. As far as social history, about a 10-year PAC history, but had quit more than 20 years prior. And then nothing else very exciting on there. Lives in a rural area of Kentucky and has not worked in quite some time. No really occupational or social exposures that we could track down talking with her. So to move back into the present case itself, this kind of occurred interestingly on the background of some progressive, essentially B-type symptoms, feeling fatigued, as well as that dyspnea. She reported a subjective 40-pound weight loss over the preceding months, and then ultimately presented to the ED primarily because of her worsening respiratory symptoms. These are her vitals when she initially arrived at the University of Kentucky. So blood pressure, okay, not particularly tachycardic. Perhaps the most arresting thing is a lower O2 saturation, and this is actually on a fair amount of high flow nasal cannula, 40 liters and 80%. We'll look at her repeat chest x-ray in a minute. Pulmonary exam, does not sound tremendous, and overall just did not look that healthy. But no rashes or anything like that, no other vocal findings on that initial exam. This is her chest x-ray when she arrives. Obviously not improving with antibiotics, obviously. And this is on 80% oxygen with 40 liters going full blast every minute. She was briefly admitted for about a day at the outside hospital before she came to us. So on arrival, we had a fair amount of lab data already available. These are some of her basic chemistries. So kind of the most arresting thing when she first shows up, creatinine of 2.73, that's been slowly uptrending. About a year prior to this, she had a baseline of 0.7, essentially normal BMP. Kind of other things to look at here, no significant anemia, CRP elevated, our upper limit of normal is in the teens. His initial infectious workup was negative. Her UA, very exciting, showing 31 to 50 RBCs, as well as a small amount of protein on the dipstick there as well. And so as I said, she'd already been admitted, so some of these serologies had been sent off and came back pretty soon after she arrived here at our hospital. Obviously, ANA was negative, but ANCA very, very positive, that 1 to 1280, essentially all in that cytoplasmic staining pattern. Looking at the more specific serologies, the proteinase 3, very, very elevated. All three of these values here have the same reference ranges, where under 19 is considered definitively negative. Anything over 26 is reported as definitively positive. So, with that number 26 in mind, PR3 very, very elevated, greater than 1300. But kind of interestingly, also with a positive MPO, traditionally associated with PANCA. And then the anti-GBM antibody as well would be considered positive based on this lab value. And just to complete the workup complements here, those are both within the reference range for our assay here at UK. So, we can have comments, anything like that as we go along, or just keep moving. But I think this is kind of the initial information that we had. So if you're playing along at home, I think this is kind of the first step where the decision is made as far as how much to treat this and how to treat this, as far as immunosuppression, plasma exchange, and things like that. So they kind of keep moving through her course here. Obviously, she arrived based on this, both the degree of illness, requiring a lot of oxygen, ultimately was intubated on hospital day 2 and had a bronchoscopy done here, which was consistent with diffuse alveolar hemorrhage. So given that, the degree of renal involvement, the decision was made to start on plasma exchange. Then also treated empirically with Cytoxan and pulsed steroids here. On the same day she was intubated. Then after another plasma exchange with FFP, she underwent a kidney biopsy on day 3 here in our institution. I think next we have some of the pathology from that first biopsy. So this is a PAS stain showing, pretty impressive crescent beginning to form here and compress this glomerulus. Maybe some ATN developing down here in this part of the screen as well. So definitive crescent seen on the light microscopy. Overall, 25 glomeruli were sampled. 8 of them had crescentic involvement at the time of this biopsy on day 3. That's after 2 plasma exchanges. And then there's also this question. We know we have a definitively positive C-ANCA, but there's also this positive GBM. So on that background, the immunofluorescence is very interesting. Here we have the background albumin staining, as well as the staining for IgG and the same glomerulus at a slightly different cut. As you can see there, there's some uptake of IgG, but depending on who you ask, I would say it's probably not appreciably different from the background of albumin. Here's the same with the IgM staining, showing even less take-up of that IgM compared to the albumin background. Perhaps not coming through too well, but this is a similar sort of slice where we're seeing the same glomerulus at a slightly different level. And then just to complete the picture, here's the electron microscopy. It was read as some modest foot effacement, 10 to 20%, but a generally unexciting GBM with no inclusions or anything like that seen. So through this portion shows essentially just in words what we've already kind of talked about. So again, we saw these fibrotic crescents at the time of biopsy involving about 1/3 of the sample glomeruli. And there's also you see changes of glomerulosclerosis in half of the glomeruli that were sampled. Again, just kind of the recap of the immunofluorescence. Again, some short uptake of the IgG and IgM, but all of this essentially was read as not significantly different from our background staining and considered a posse-immune immunofluorescence based on that. And the official read of the electron microscopy. So kind of the official conclusion that was reported out by our pathologist here. We had this sort of pan-positive initial serological workup. The findings on IF and light microscopy, though, were felt to be much more consistent with a posse-immune glomerulonephritis. And they essentially read it as no features consistent with an anti-GBM glomerulonephritis. So, based on that, you can kind of form your opinions on, the further management steps as far as plasma exchange and things like that. Patient did fairly well from there after starting Cytoxan and undergoing Flex. So again, was extubated on hospital day 4. These titers were followed serially. Collected on day 6, that anti-GBM came back negative on day 8, which was the day of our 8th and last plasma exchange. Continued improved, ultimately discharged a week after that with a creatinine of around 2, where it stayed since. So I think that just to talk a little bit about the long-term management strategy, she was tapered off steroids, ended up getting 7 total doses of Cytoxan as an outpatient, but that was unfortunately complicated by a number of cytopenias. Ultimately transitioned to azathioprine about 6 months after the Syndex hospitalization, and has done fairly well since. Continues to have a degree of chronic renal insufficiency, but hasn't had any relapses since that first hospitalization. And I think this just covers the kind of what we've seen since then. You can see creatinine is sort of stabilized out here, following these serial titers as well. PR3 and NPO have stayed at the lower end of what we expect to see. So I think that's kind of the full course of this case. I don't know if anybody has any questions or anything that we can clarify right away.
So it seems she was treated initially as an anti-GBM, but after the biopsy and everything, it was PR3, case of vasculitis with posse-immune, ANCA-associated vasculitis, right?
I I think that's kind of the big picture takeaway, although that's kind of, I think reasonable people could disagree. When she was being treated here, it was approached almost as a GBM, where we followed these serial titers and continued plasma exchange until they were undetectable. The question would be how pathogenic these anti-GBM, whatever was read there, actually was if it didn't show up in the immunofluorescence. And I think, have another slide just kind of speaking to the fact that, potentially I wonder if that could have been a false positive of some sort, because there's actually a disclaimer that comes with that lab, suggesting that if there is a lot of inflammation, you could have reactions to other parts of the type 4 collagen molecule.
Thank you, Sam, for this well-managed case. I'm sorry because the voice is a little bit not clear, but I can conclude it's a case of Rpgn, ANCA-associated vasculitis, and the biopsy shows recent glomerulonephritis and immune Rpgn with successful management using plasma exchange. This just to conclude the case. Am I right?
Right. Plasma exchange, of course, on top of the cyclophosphamide and steroids.
I see. And this actually, can raise the possibility of using plasma exchange in cases of ANCA-associated vasculitis, in spite, as Professor Sadiq mentioned in his elegant talk, most of the studies actually did not recommend plasma exchange. I'm a little bit worried about the anti-GBM. I mean, by immunological diagnosis and by renal biopsy, it is boosty immune, isn't it?
Right. So whatever serology, I mean, she was positive, double positive serology. Even the anti-double strand also was positive on top of the anti-GBM and ANCA, but by the end of the day, she is not lupus, she is not anti-GBM, she is boosty immune ANCA-associated vasculitis, and the BR3 titer was very, very high. So I would consider, the BR3 positive, granulomatous polyangiitis more than anything else.
Okay, so long as we don't have any questions from the audience, we would like to thank Sam Bevan for this interesting case, and we'll move to the last part in our meeting today. Rasha Samir will answer the quiz. Rasha, please do it quickly. Rasha, are you ready with the answers of the quiz?
Yeah.
Okay, please go on. Please, Rasha, share your screen.
Yes, I'm sharing. As I know you're late in time, I'll try to cut it short. So, regarding question number 1, which one of the following combinations represent the first line therapy in a patient with class 3 and 4 lupus nephritis? So, according to the approach presented by Professor Reuven, patients with class 3 and 4 lupus nephritis start with methylprednisone, MMF, or cyclophosphamide for around 2 or 3 months. And if the patient is not stable or there is no adequate response, there will be the time to add on newly added therapies. So the answer of this question will be steroid plus cyclophosphamide and MMF. Regarding question 2, with the most reported adverse effect with the use of vocalosporin according to the Aurora 1 trial, pneumonia was the most frequently reported adverse effect. Regarding the mechanism of action of belimumab, Belimumab acts by blocking the binding of soluble Bliss, which is a B cell survival factor, to its receptor in the B cell, B lymphocyte. Question 4, which one of the following is correct regarding the use of belimumab in management of active lupus nephritis? The correct answer is that, the long-term use of belimumab confers better safety profile compared to traditional immunosuppressants. This is the incorrect answer, as long-term data are not yet available. Which one of the following regarding the use of vocalosporin is incorrect? Vocalosporin is a new generation CNI with similar potency to inhibit the activity of T cell. It has better metabolic profile compared to other CNI. Ludus has shown high complete renal response rates in clinical trials. Vocalosporin is recommended as add-on therapy to MMF and Ludus steroid in patients. Correct. The incorrect one is the monitoring of vocalosporin needs monitoring of the trough levels to prevent overdosing. Question 6 regarding the patient who was 60-year-old diagnosed with one of the thrombotic microangiopathic syndromes, so it seems to be TTB. Which one of the following treatment options will be the next step? Starting plasma exchange is recommended to be carried out in any patient with suspected TTB, and the diagnosis will be confirmed later. Question 7 regarding the patient with hepatitis C who is presenting with Cryoglobulinic Vasculitis. What treatment options is recommended or are recommended for this situation? Initiate hepatitis C antiviral therapy, plasmapheresis, corticosteroid, rituximab, and I think all of the above is are correct in this situation. The last question. In a patient who's 55-year-old with a diagnosis of anti-GBM, glomerulonephritis, which therapeutic modality is most likely to be beneficial in the next few days? Intravenous immunoglobulin, plasma exchange, azathioprine, prednisone 20 mg per day, mycophenolate mofetil plus prednisone 20 mg per day. The correct answer is plasma exchange. That's all. Thank you.
Thank you, Rasha. Thank you very much. So we came to the end of this fascinating event. And before I close the event, I would like to thank all the excellent and eminent speakers, starting with Professor Amr Husseini, Professor Patrick Neckman, Professor Brad Rubin, Professor Ahmed Siddiq, and my co-moderators, Professor Dina Shaheen from Egypt, Professor Ahmed Abdel Wahab, Dr. Rasha, Dr. Shayma, and Dr. Sam Bevan. Before I say goodbye, I would like to announce for the third coming course. It will be on 28-29 July 2022. So please make your agenda and we'll be happy to meet you on the time. I know it's hard to say goodbye and we will miss all of you for this couple of months. If any of the moderators would like to comment, they are more than welcome.
Thank you so much.
Thank you, Dr. Ala. Thank you, Dr. Ala. Thank you, Dr. Am. Thank you for all participating professors and colleagues.
I want to thank Rasha, Samir. Thanks for her because she was very special. She was working behind the scene, communicating with everyone, and she worked very hard on this. So special thanks to Rasha.
Thank you very much, Dr. Am.
Sure. Another thing I want to announce that there will be an evaluation for this course. Please give us your feedback, and there will be also certificates for the attendees. So after you fill in the evaluation form and give us your feedback, you will receive the certificates of attendance. And thank you for everyone who participated in this fascinating meeting.
Thank you very much and see you.
Bye.
Thanks Brad. Thanks Professor Neckman. شكرا يا دكتورة دينا على الحضور.
Thanks. Thank you so much, Brad and Patrick and Dina and everyone. You know, it was very, very nice to see you, and your contribution to this meeting was very nice and informative and thoughtful. Thank you.